hello everyone around the world. The Sarcoma Alliance is excited to bring to you today our Women in Sarcoma webinar featuring prominent female physicians serving in the sarcoma space. Today, they are volunteering their time to answer all of our questions, or at least some of them. There were a lot, and we're really honored to have them with us today. I'm Alyssa O'Driscoll. I'm the Executive Director of the Sarcoma Alliance. We are a nonprofit charity serving more than 10,000 people annually with our programs and services to provide guidance, education, support, and connection for everyone affected by sarcoma. Dr. Gina D'Amato serves on our board of directors and will be moderating today's question and answer discussion. She's a medical oncologist at Sylvester Cancer Center in Miami. We're also joined by 4 additional esteemed female physicians. Dr. Neeta Somaiah, who is a medical oncologist at MD Anderson. Dr. Shree Venkat, who is a radiologist at Sylvester. Dr. Breelyn Wilky, a medical oncologist with University of Colorado. And Dr. Kristin Rojas, who is at Sylvester, a surgical oncologist and specialist in sexual reproductive health. So we received a ton of great questions ahead of our time together. Thank you, thank you. We'll try to get to as many as we can, and we do have an hour today. So if you do have questions that you'd like to ask, feel free to ask in the chat. I know our physicians will also be responding there as well. And so since we have an hour together, I'm just going to go ahead and turn it over to Dr. Gina D'Amato for the remainder of the time together. So Dr. D'Amato, the floor is yours.
Well, first, thank you so much. And first of all, I just want to thank Sarcoma Alliance and all these amazing women panelists. You know, we're all they're all extremely busy trying to, you know, come up with research better treatments and help patients. And so really want to thank them for taking out their time to answer questions. I will give a shameless plug for Sarcoma Alliance, and that they do have these really cool masks that you can see and you can purchase. And purchasing the masks, number one, you can look cool and protect yourself. And number two, it does raise money for the Sarcoma Alliance. And we will be giving these to our panelists in appreciation. Obviously, we would love to, you know, spend the money on you, but, you know, we want to help patients, but we will be providing you guys with these cool masks. And I just announced that now. So Alyssa's probably in shock about that, but she'll be fine with it. Anyways, so let's just get started. There's tons of questions. I'm sorry if I don't get to all your questions, but hopefully some of them, you know, are kind of similar. And so let's just go straight up and talk about the sex. It's a very kind of topic I don't like to really, you know, talk about. I get all flushed. I don't know if you could see my face is getting red, but we do have an expert here. So let's talk about hormones and go straight to that topic. Okay, so I have so here's a topic. I'm a cis-female. I'm curious if Dr. Rojas can speak about physical and emotional effects on treatment and sexual functioning during treatment and following successful treatments. So let's just open the agenda for that embarrassing topic, get it out of the way.
Amazing. Well, thank you so much, you guys, for inviting me to be here. I think that I'm obviously biased, but I think this is such an important part of taking care of patients with cancer, specifically women with cancer. You know, it's an often under-addressed issue. You know, we didn't talk about this for a long time, and now I think I'm so glad to hear that patients are asking the question, and we're trying to learn more about resources for women like you. And so, you know, if you look at the pharmaceutical industry, there are like 6 types of Viagra out there, and there's like not a lot of options for women, and there's even less options for women with a history of cancer. And so the first thing to know is that it is so incredibly common. You know, women, whether it's an effective surgery or radiation or chemotherapy that either puts you into early menopause or maybe makes your menopausal symptoms worse. More than 80% of female cancer survivors report this. And so the first thing is you are not alone. And so ask the question, ask your doctor, say you're having these symptoms. The most common are painful sex or vaginal dryness or hot flashes. And so some of my best practice tidbits of information, best practice pearls, to get patients at least started on treating some of those issues is first, to just avoid putting anything on that delicate skin that could be potentially irritating. And so that means any products with gimmicks, like warming products, lubricants that have flavors or scents or anything with fragrances or harsh soaps or chemicals. With regards to painful sex, I always talk to patients about using lubricants that don't have any extra of those long name chemicals. And then, but painful sex is probably the most common symptom, whether it's from previous surgery or chemotherapy that makes dryness worse. And so I would encourage all of everyone listening to, talk to your gynecologist, because there's a lot of different reasons women might have painful sex. Some are related to dryness, but others are related to some pelvic floor muscle dysfunction. The pelvis is kind of like a basket like this that holds everything together. And so, we have pelvic floor physical therapists that can help with that. And if you live in the South Florida area, you can come see us at the Sylvester program, but also we're working on putting more information out there for women everywhere who are experiencing these issues. So.
Thank you. So on the topic, let's talk about, we know we have some uterine leiomyosarcoma patients, and we had questions about the use of aromatase inhibitors and how long patients need to be on aromatase inhibitors. Are they really effective? And so I want to talk, I'll ask Dr. Wilky about what her experience and Dr. Somaiah, if they want to talk about hormone therapy for estrogen positive uterine leiomyosarcoma.
Thanks so much. Again, thanks to everybody for inviting me to be a part of this. So what I tell people is, the uterus definitely is driven by estrogen and progesterone normally. And so all of those tissues have the little antennas that are designed to pick up signals from estrogen and progesterone floating around the body. That's how the uterus works. When you have a cancer, though, generally leiomyosarcoma is happening because there are other mistakes. There are other damaged genes within the uterus that are driving the cell growth. And so while, it's very tempting when you test the sarcoma and see, hey, look, those antennas are still there. In my experience, it's very few patients where blocking those normal receptors is enough to overcome the effects of the broken genes, the broken drivers that are actually making the cancer have a lot more problems, grow, spread, all of those different things. So I typically say, if it's somebody where adjuvant therapy, so after you have your surgery, maybe we're looking at not doing chemotherapy, but you feel like you want to try something, that's really the only situation where I might consider it, is in that setting. Dr. Somaiah, what are your thoughts?
Pretty much exactly similar. Rarely have I found it useful for a leiomyosarcoma, though I must say in rare cases when even within leiomyosarcomas, even if they metastasize or recur, there is differences in the rate of growth. So there are some leiomyosarcomas that are these slow growing, late recurrences with a solitary met. And if they still have a very high expression of ERPR, and if patients are really keen on doing something, sometimes they have taken hormonal agents and I haven't exactly prevented it, but it's not something I would recommend. So it's not a primary treatment for uterine leiomyosarcoma, just as Breelyn said. They express the receptors, doesn't mean necessarily the LMS is driven by it. And I was just going to make a plug. I saw John Trent on the panel here, who's not a woman in sarcoma, but he is there, and, which is great to have him. So if he needs to direct any questions to him, we definitely can. But anyway.
Yeah, he was pretty much all of our mentors. I mean, he was our, well, not yours, but he was Bree and I as a mentor, and it was actually his idea to do the sarcoma women in sarcoma panel. So, He's our honorary.
He's checking in to make sure we're doing well. Yeah.
Okay, so yeah, so I think my experience with hormonal therapy is that yes, I mean obviously for low-grade endometrial stromal sarcoma, that could be effective, and as Dr. Wilky said, if we're trying to if they're trying to try to prevent it from recurring. And, I do have some patients on there, and we don't really know how long patients are supposed to be on that if we are giving in the adjuvant setting, because we don't have any data. And that's part of the problem with some of these questions. Why, I think there was another question about why are there different opinions? The problem is that we don't have a lot of, there's so many different kinds of sarcomas, and there's so many different, where the location is, and it's rare. So we as physicians, we like to be driven by the data. I do have some patients that I put on hormonal therapy if they've had a lot of chemotherapy and they're time for a break from the chemotherapy. And they're afraid to be off chemotherapy, but the toxicity of the chemotherapy, there's only so much you can be on. So we can try it there. But again, there's not a lot of data on that. But we do have, several patients. I see someone coming that they've been in from our since 2005. We do have some patients that maybe they don't, maybe that's the only abnormality on their cancer. But, we just don't have data to say when to stop. It's more like a superstition kind of thing, I would say. Here we have, let's go with, there were some topics about like survival. I think there was a lot of questions about like, is it true that that it's a 5-year expectancy with people with sarcoma? There was another question about my doctor, gave my sister only 2 to 3 weeks to live with pleomorphic rhabdomyosarcoma. Another question, my body, when a patient's body's been severely damaged by treatment, is it ethical to keep patients alive? So let's talk a little bit about what survival is and how we determine that. I don't know, Dr. Somaiah, if you want to tackle that topic.
So again, I find the survival question a little tricky, because when people read online, firstly, all sarcomas are not alike. And when we talk about 5-year survival, it's because of the way the studies are designed. And so the endpoints that come out are, we talk about median survival, which is, 50% of the patients are still alive at that time point. Or we talk about 5-year survival because they're endpoints that we've been collecting data on the trials for. They don't necessarily indicate for a specific patient what your survival is going to be. It just gives you an indication for the whole group. And it all kind of depends on whether you respond to that particular therapy, what is your type of sarcoma, and how you've been doing overall. So it's a discussion that I think, definitely needs to be brought up with patients so that they can have in general an idea. Well, some patients like to listen or like to talk about survival endpoints, and some don't. So again, if you want to, you need to ask your physician about what to expect. But I think it's kind of a moving target. So don't get depressed or put down by hearing a 5-year survival of 20% or listening to a median survival of 2 years with metastatic sarcoma. Sometimes it does not necessarily mean it is for you. So, and those are coming from our trial endpoints, and it's for us to determine one drug versus other, which is better, and just, figuring out what sequence to use the drugs in. That's where it's useful for us, and it's useful for the FDA to determine if one drug is better than the other because it improves their 5-year survival. Okay, so I don't know if that necessarily answers the question, but I'll let the other panelists chime in as well.
Dr. Wilky, do you have anything to?
Yeah, I mean, I agree. I tell patients, the survival statistics are literally such a huge range. I mean, to say that every patient with metastatic sarcoma, has a 20% 5-year survival is just so oversimplified, right? Because there's 150 different types of sarcomas, probably more now, because it keeps going up. And then even within those same types, patients can be so different. I've had people live with metastatic sarcoma for 10 years or more. And then I've had people where it moves very, very quickly. So I tell people, give us a couple of months. Let's see how things go with treatment. And as we move forward, we get more information to be able to determine your particular prognosis, or at least to have some guidelines for kind of planning and thinking about the future.
Yeah, what I tell people is that, you know, you can live with cancer in your body as long as it doesn't affect the function of your you need your major organs to live: heart, lungs, liver, kidney, brain. Maybe I joke about the brain, you know, do you really need it, right? And so that's what's going to keep you alive, keeping the organs working, your vital organs. You don't need all your organs, just those vital ones to keep you alive. And so the goal of treatment, and as long as it's, you know, your organs are working, you can live. And then it's a philosophical how much someone wants to continue, you know, what their quality of life is, you know. So that's where someone may say, you know, because there was a question about, is it ethical to keep somebody alive? Well, just depends on what their goals, if they are okay with maybe not having their same life as they had before. Maybe they are not that active. Maybe maybe they can't walk. Maybe they are bedridden, but they want to be alive. That's up to that person, as long as the person's not suffering. And, you know, we have different levels of suffering. So, you know, as long as you may think someone's suffering, but they don't think someone's suffering, that they themselves are suffering, or they're at peace at what their life has been resorted to. So, you know, and we can keep people alive a lot longer than the studies, because the studies were done before, and now we have newer treatments. And again, the studies aren't necessarily going to pertain to your particular cancer.
But I mean, Gina, I'm sorry if I might just add with the ethical thing, though, if it's true, but it's good to get, you know, the opinion of your physicians if things are really, you know, going down south, as to when is it, just as you said, when is it not wise to prolong the suffering? And, you know, again, it's always a combined decision making, but, you know, getting your physician's opinion. So sometimes you keep wanting to do things, and some physicians just keep recommending things, but if that's too much and you want to, you know, you want to get a quality of life picture and figure out that you want to stop doing further therapy and just focus on quality of life, that's okay too. Just, you know, have that discussion with your oncologist.
Yeah, that's a very good point. And you need to have these discussions with your family members so that they're aware of what your goals are and what your wishes are before, because they may be pushing you into things that you don't want to do because they don't want to lose you. And or they may say, oh, they don't think you can handle it. So, you know, you need to be open with your family members and letting them know, you know, what you're willing to do and what you're not willing. Let's see. There was a question for Dr. Venkat. We'll get her back. We'll get her in the hot seat. So Dr. Venkat is a radiologist and interventional radiologist. And for Dr. Venkat, can you talk about non-SBRT options for lesions on the liver or near the kidney, cryoablation, ablation, et cetera?
Sure, I actually can. This one I can handle. And a couple of notes about when you meet your interventional radiologist, meet them before you have procedures, because you have to realize with us, we are the outgoing group of introverts. So like radiologists like to hang out in the dark, not really talk to people. The IR group, we're trying our best, but we're still learning. We're not as good as your oncologist. So a lot of times when you meet us, know as a patient, you're going to know your disease process better than I do, because it'll be something new that I'm working on pronouncing or looking up. So forgive us for that. From a procedural standpoint, what do we look at when we try to ablate or approach a lesion? we try to compete with surgeons. We're a competitive group. And so a surgeon can take out a tumor, hold it in their hand, give you what I call gross pictures, and literally gross pictures, and say, I got the margins. And then they have their pathologist in their back, you know, helping them, saying, you got it, you didn't got it. You know, that's the people who judge them. For us, we are our own worst enemies in the sense that we look at images and check our margins and say, did I get it? Did I not get it? So you have to plan and manage expectations. So something like a 2 centimeter tumor is something where I can come with an ablation probe, 1, 2, 3, 4 needles, however many I need, and get you 1 centimeter margin. So I'm making something that's 2 centimeter and making a 3 centimeter area. When we go into sarcoma world, what you ask out of us is very new, and it's bigger than what we're used to. So you need to find someone, especially with cryotherapy, where you can. And I have treated desmoids that are on the order of 8 centimeters, 9 centimeters, 10 centimeters. You have to be comfortable, one, doing longer cases, have the support to do those, and work with your patient and your family to realize that, you know, maybe I won't be able to get all of it at once, but I'll come back and treat more. SBRT is beautiful in the sense that there are no procedures. All that the radiation oncologists do is all in the pre-planning, where they do mapping with your imaging, they gate to your respiratory rate, and you don't ever penetrate the skin. For us, we're minimalists. We're trying to do what a surgeon does through a scar, through tiny, tiny incisions. So it takes us longer. So these procedures, depending on size and shape and location, you're talking about general anesthesia from anywhere from 4 to 8 hours. And that's kind of what we're looking at. So the options are all there. But a lot of times you as a patient may have to be the one to engage in the conversations like, hey, I'd like to know what your IRs can do, and just meet us. We're all doing telemedicine. We all have clinic. And even for biopsies, I meet a lot of patients to discuss biopsies and approaches and what they need. And then you have to realize what you're comfortable with. If you have had a biopsy before and it was a terrible experience, tell your interventional radiologist, I need general anesthesia for this. And they have to honor that. And it's a different setup. So the options are there.
Thank you. Okay, this is for Dr. Rojas, since she's a surgeon. Can surgeries cause more tumors? Because every time I have surgery, a week later, I have another tumor.
Yeah, that's a really good question. And, you know, I always say in the olden days, then I realized some people get offended with that. But back in the day, you know, we did think that maybe there was something about doing a surgery in an area that would cause like local inflammation and potentially increase the risk of a new cancer developing in that area. And there is something to be said about, you know, a patient going in for surgery and there being a big inflammatory response that their body feels, and what that means for, you know, little cancer cells that might be floating around in the body trying to find a place to land. And that's an important question, but right now we don't have any data showing that one surgery increases tumor growth either in the same location or in another location. Now, there are newer techniques that we're using. One of these is called like enhanced recovery after surgery protocols, or ERAS protocols. And we're using them in breast cancer surgery, but they can be applied to any type of cancer surgery. And this is when the surgeon gives you medication before going to the operating room. So while you're in the holding area, to treat pain before it even starts, gives you an NSAID, or an anti-inflammatory medication, while you're asleep to decrease the inflammation. And then we treat you with all these other types of medication, non-opioids, that are kind of to decrease the inflammation and minimize the pain you would feel after surgery, because we know that pain is an inflammatory process. If we can minimize the amount of inflammation and the big insult that to your like equilibrium that your body feels around the time of surgery, then the idea is that, number one, you'll not only get back to your normal life faster, but number two, in the event that there are any little cells of cancer floating around trying to find a place to land, that it may decrease that risk. And so ask your surgeon about ERAS protocols or ways to treat pain or minimize pain and inflammation around the time of surgery, because this is a brand new area of research and something that I'm looking at. But I mean, it makes sense logically, and this is what we're trying to do. But always ask your surgeon, you know, hey, I heard that maybe we can do some things to manage my pain and decrease inflammation at the time of surgery. Have you heard of that? What do you think about that? And see what they can do for you.
Okay, and now we have a lot of questions on specific types of sarcomas. So this will be mostly for Dr. Wilky and Dr. Somaiah. So some questions. Any new treatments for Myxofibrosarcoma or pleomorphic undifferentiated sarcoma? Are there promising new treatments?
Well, I can start, I guess, but Breelyn. So, pleomorphic undifferentiated sarcoma or undifferentiated pleomorphic sarcoma and myxofibrosarcomas in that category as well, somewhat, have come into the limelight over the past couple of years, I guess, because of the first reported responses with checkpoint inhibitors, so kind of immunotherapy. So traditionally, the standard therapies that we have used for these tumors are chemotherapy, and they do work well, but not in every patient. So it's chemotherapies that are either adriamycin-based, or that is doxorubicin-based chemotherapies, or gemcitabine docetaxel-based chemotherapies do work for UPS. But these tumors, tend to probably have a lot more abnormalities that make them immunogenic in some ways. So, the early trials reported a response to checkpoint inhibitors anywhere from 20 to 40% in terms of shrinkage in this UPS sarcoma category. So there's a lot more research that's ongoing to better define the response, to figure out why some patients respond, but others can progress pretty rapidly on these immunotherapy agents. They're using, a lot of trials are ongoing to try to use this in the neoadjuvant, that is before surgery setting with radiation, that seem to have good response. So I think a lot is going to be learned. It's still not a standard option, but there are clinical trials available with immunotherapy for UPS. So if folks are, after their standard chemotherapy, are looking at other options, I would highly encourage them to look at those, because those are promising. Breelyn?
Yeah, I agree. So we're both immunotherapy nuts. So we're both super excited about immunotherapy as an option for these tumors. The issue is that when it works, it's amazing. And you can see patients who had progressed on multiple different types of chemotherapy, little bit of immunotherapy, they feel great, and tumors are shrinking like crazy for a long time. But then I've seen patients where they should have responded and it just grows, maybe even faster than it did before the immune therapy. So yes, I think every patient deserves a shot, particularly if you have UPS, but there are more and more trials with new combinations that may be able to set up your chances for success a little bit better. So that's point one. And then the other thing I'll just mention, so my new current favorite target, which is in several clinical trials focusing on UPS especially, is a protein called AXL. And so AXL is, again, one of these little antennas that's on the surface of the cell that is highly expressed in many, many different sarcomas. Up to about 70% of sarcomas may have AXL on their surface. So there's some really cool new drugs being developed that are kind of like Trojan horses, where the chemo is piggybacked onto an antibody that binds to that AXL and then drops the payload right at the tumor cells. So if I had to pick my current favorite new target or new treatment for UPS and myxofibro, that probably would be up there.
And that's something that you would pick up in the genotyping results. And then, so getting, the other thing to do for UPSs would be to make sure you get your tumor genotyped at some point. And that helps with picking out targets. But yes, AXL is one. Thanks.
And how do there was a question on there are new clinical trials. How do we get access to those clinical trials? How do patients find out about those clinical trials? I know we have one here at Miami that we're going to be opening soon, immunotherapy for the pleomorphic. It's not, and I'm sure, I don't know if you guys have those trials. I'm sure you do opened already, but
yeah, it's hard to keep up with the trials. I mean, the main database is called clinicaltrials.gov, but it can be really challenging to navigate. It's not always up to date. So I think really having that relationship with your oncologist and reaching out, if you're at a point where you're making treatment decisions, that's the time to try to get a second opinion with a big sarcoma center that will, even if they don't necessarily have the particular trial that might be right for you, they'll probably have heard about it or at least have come across it in meetings or groups like these, so it's always worth considering clinical trials along the way in that way.
Yeah, totally agree. I mean, each one of our centers have trials that are open at our center, but also trials that are open at multiple centers. And reaching out, if we don't have the trial open, we usually, it's easier for us to look at clinicaltrials.gov because we know what we're looking at, and then provide you data of where else the trial might be open if it's closer to you. So that's definitely, as Breelyn said, when you're looking at a treatment change, that is the time to look into clinical trial options.
We have another question about pleomorphic rhabdomyosarcoma and potentially like recycling previous treatments, repurposing the medications. Do you guys do that where you've had treatment in the past and it's worked and going back to it?
So for repurposing, do you mean going back to a treatment that they previously had, or you're saying, or are they talking more about using drugs that were not necessarily for sarcoma, maybe for something else and trying?
I'm not sure. Would the repurposing of medications work for? Yeah, I'm not sure. Maybe that was a little bit. So I would say, sometimes patients do well with certain chemotherapies, and then they get a break and they try something different or have a break, and we can go back to the ones that did work. Doxorubicin, for example, because now that we're giving doxorubicin with heart protection, we can actually go higher on the doses of the doxorubicin than your quote lifetime dose. But pleomorphic rhabdomyosarcoma is a little bit of a tricky kind of sarcoma in that we use the treatments that for standard rhabdomyosarcoma, but then which may or may not work. And then we can also use the treatments for standard soft tissue sarcoma or high-grade soft tissue sarcoma. So, but yeah, we can use multiple different treatments for that. I guess maybe that. Anything else? Okay, we have a question on osteosarcoma. Any new treatments for osteosarcoma out there?
Yeah, so for osteo, the one I'd point out is Andy Livingston's trial at MD Anderson, which is a fantastic immunotherapy protocol. So that's kind of like my favorite trial right now. But Dr. Somaiah, other thoughts?
Yeah, so I would again, Andy Livingston has the trial open, which we have for D. diff, liposarcoma, angio, and osteo with durvalumab and oleclumab, but he has other trials in the pipeline. Because again, even though we have a lot of hope for immunotherapy in osteosarcoma, we still have to see those responses. And all the trials right now are trying to improve on looking at other factors that might be causing resistance to those immunotherapy drugs and doing these combinations to try and improve the response. So in terms of targets, again, there was also a TIL study, which is tumor infiltrating lymphocytes, where you inject lymphocytes, and we did see some early responses, but we still need to develop those trials in order to get long-lasting responses in osteosarcoma patients. In terms of targeted therapies or other targets, I don't know, Breelyn, but there are targets in osteosarcoma, but I'm not aware of any specific trials with targeted therapy. It's all in combination with immunotherapy that's out there.
Yeah, osteo is eligible for the AXL study, so that's one thing to consider. But again, really limited data so far about how that's going to work.
Correct, and yeah, to that point, yes. So again, on the genotype, there have been we've partnered with our phase 1 colleagues. So there are a lot of trials that we are placing osteosarcoma patients in, but none that I can say for sure is showing responses and will direct patients to it as of now.
And I'll ask Dr. Wilky this, alveolar soft parts. You're kind of expert in this. What about anything for alveolar soft parts?
Well, so what we've learned through now an incredible number of trials compared to how rare ASPS is that immunotherapy definitely has a role. Dr. Somaiah's study, the Durva-Tremi study that was done had ASPS patients. The Oxy-Pembro study, there's a bunch of different studies that have looked at these patients. So the two big things for ASPS are the immunotherapy, but then also our targeted therapies. And what we still don't know is what order do they need to go in? Is combination actually better than one after the other? There's a lot of unanswered questions. And so what I generally do, because again, there are ongoing studies for ASPS in both of those. So there's a drug called anlotinib, which has a dedicated ASPS cohort. So I'll try to get patients towards that because it's a very broad and a really good, well-tolerated anti-blood vessel drug or a chemo pill. And then we try to use immunotherapy combinations or atezolizumab, which has been studied, or combo ipi-nivo. I mean, there's any immuno trial will probably do if they're eligible for that. But again, with ASPS too, sometimes you don't have to be as aggressive. And so it's another one of those diseases where really understanding the individual patient and the individual prognosis is important before you jump into some of these treatments.
And what about for the adjuvant setting for that? I think we don't really, there's no trials for the adjuvant setting. I think it's just
so few actually are localized, right? It's what, like 5 or 10%, I think, that present with only one side of disease, because unfortunately these patients will tend to have metastatic disease at diagnosis. So at that point, if you can have surgical resection, take it out and then just watch really, really carefully and for a long time.
Okay. Now we have some questions. We have a question on desmoplastic small round cell tumor, and the treatment is about 1 year of chemo, 5 different chemo drugs. Is this typical for a DSRCT, desmoplastic small round cell, and what is the recurrence rate? I mean, I can just tackle that one. I mean, I think the DSRCT, is similar, is an aggressive sarcoma similar to Ewing sarcoma, but we treat it with the Ewing's protocols, and we try to be as aggressive as we can for a long time with chemotherapy. There is the high rate that it can recur, but there are patients that can be cured of it. So we try to be as aggressive as possible with the treatment. A lot of times patients are diagnosed where it's already spread and it can't be cured, but we can keep it under control. Now, if you guys agree with that question or have anything, it's a tough one, but there's research going on, so we still have hope. All right, there's another question, some about, the leiomyosarcoma. This one is a technical one. So this one, I think there must have been a doctor on here or someone that has been dealing with it for a long time. But do you think genetic analysis of sarcomas are going to result in reclassification and treatments geared to the genetic makeup? For example, high-grade endometrial stroma with the B core IDT. I think maybe we don't have a pathologist on here, but I don't know if Dr. Wilky or Dr. Somaiah want to talk about a little bit of how the tumors, how we've reclassified some of these sarcomas.
Yeah, I think the first thing, so I had a patient even this week that came in with an uncharacterized uterine sarcoma. Like that's all she had, right? And there's so many different varieties of uterine sarcomas, and the treatments are incredibly different. So I think the genetic testing, particularly if you can't make a slam dunk diagnosis on the regular pathology, can be so helpful just to try to even figure out what you're dealing with. The question though is, okay, so now you've got these genetic results. Do you actually have treatments that have been proven to be better or worse for those particular abnormalities? And I think that's really still where we have a lot of work left to do. something like high mutational burden or Lynch syndrome, or something where, there's an association with potential benefit to immunotherapy. That's kind of the home run that you hope to see on those tests. Or something called an NTRK fusion that has NTRK inhibitors that are like magic bullets. I mean, that's what you are really, really hoping for. But the vast majority of the time, we don't have those answers. We don't have great drugs for a lot of what comes up on these.
I have another patient that says, I have high-grade endometrial stromal sarcoma. Are there any new advances or knowledge about this type of sarcoma? I think, this one is a tough one also, but, actually we have our Women in Sarcoma group that we chat together, and Dr. Sanfilippo discussed her protocol of high-dose ifosfamide, which we give here, and it's over a 14-day course, and she recommended it to one of the patients, and we just found out that patient had a great response. So, there are different chemotherapy regimens available for that, and we're working together to help the patients. If anybody else wants to comment on the high-grade endometrial stromal.
It's a tough one.
It's a tough one, but we can be creative, and it can be definitely sensitive to high-dose ifosfamide.
Hey, Gina, there's a question on the chat that I think is really important to address. So
okay, good. Yes, because if you can, because I can't.
You can't do both. I know.
I usually have my dual screen, but I'm only on my laptop here, so I'm trying to. So yes, if you want to address that, perfect.
The magic question that I spend at least 15 minutes tacked onto every visit: can sarcoma patients get the COVID vaccine? Should we?
Oh, yes.
What if you're on chemo? What if you're on immuno? Like, who should get that vaccine, and how does that impact care? Now I'll turn that back to you, Dan.
No, why don't you answer?
Oh, no.
Let's talk about
COVID vaccine. Well, I'll tell you what I tell patients, and then we'll see if the others agree, because this is all very recent. So right now, if you have access to the vaccine, definitely get it, but talk to your oncologist about the timing with regards to what therapy you're on. So if you're not on any therapy, there is no increased risk in terms of side effects unless you have allergies. So you definitely recommend that you go get the vaccine, get protected if it's being offered to you. If you're on chemotherapy that can suppress your counts, what I've been telling patients is I would like for them to have at least a little bit of recovery of their lymphocytes. So depending on the regimen of chemotherapy that you're on, usually a week after, and then to not get your next chemo at least for 2 weeks after your vaccine. So you have a 2-week period to develop some form of an immune response. Again, not so much data to support it. And what we are doing is for patients who are getting vaccination, and MD Anderson's just started rolling out vaccination for patients in a phased manner, is to collect that data of what is the immunity that is being generated depending on the stage or, the patient's treatment cycle that they're on. So that will be data that will be forthcoming. But right now, given the risk and given the availability for vaccine, highly encourage you to get it, but talk to your oncologist with regards to timing.
And just remember, so many patients are asking me if it's safe, if they're at higher risk for reactions, or if it could hurt them. This is not a live vaccine. There is not a single piece in this vaccine that has anything that's been derived from the actual virus. I saw this great analogy on Twitter where basically it's like an email that we're sending to your immune system. It's a piece of code that tells your immune system what to do, and then it disappears the next day. It hits the delete button. So this, for people that are concerned that with a lowered immune system or fighting cancer that it might be dangerous for them, that's not the case. The worst case is that your immune system just doesn't form as good of a response to that trigger as it might if you weren't on chemotherapy or some other treatment.
Yeah, so this pertains because there was a question about, will it interfere with the Ibrance and things? So it's not going to interfere with any of your treatments. Again, the timing is important. And the only people that we're not recommending it to are people that have had allergic reaction or a bad reaction to the flu vaccine. So, you know, if you've had that, you may want to wait a little bit, or you may want to discuss the pros and cons with your physician if you've had a really severe allergic reaction to the flu vaccine. As far as the rollout is concerned, it's per the state. And so, you know, our institutions, we're trying to get it as soon as possible. So each institution has their cutoffs, you know, at University of Miami, where it's over 65 and multiple medical problems. So we have not yet been able to get it for our patients or most of our cancer patients, but it's coming. So, you know, if you're over 65 and you're in a certain state that they're rolling it out, you may need to get it somewhere else besides your institution because they may just not have enough. And so, but it seems like the physicians aren't ordering it. It's just kind of, so it will be coming out, and most people, it will be very safe. But again, you'll talk to your physician about it. That was one of the questions on the paper too. So, but thank you for bringing that out. And then let's see. Now we had some questions about doxorubicin. What was the question? Sorry about that. I got sidetracked here. Okay. I have stage IV Leiomyosarcoma with metastatic disease along my spine and lungs. Are there any new treatments that I should consider? So what about leiomyosarcoma? What are some of the treatments? Anything new out there? I think Dr. Somaiah, we're putting her on the hot seat.
Well, you know, again, my thing with leiomyosarcomas is, again, I don't know the history of the patient, if they've received other treatments and, you know, what their condition is. But I still favor standard chemotherapy, either adriamycin-based therapy or gemcitabine-based therapy. And again, the slight differences if it's uterine leiomyosarcoma versus non-uterine leiomyosarcoma in terms of the choice of chemotherapy agents. I think those are still the ones that we can say we have proven efficacy. And again, if you're one that responds to it, you can have, you know, a great response. And, you know, even patients with advanced disease can sometimes get eligible for localized, like surgery, local therapies, or even IR, interventional radiology, ablation techniques, depending on how widespread the metastases is. In regards to newer treatments, and of course, after that, we have, you know, Votrient, which is pazopanib. Trabectedin has been approved for leiomyosarcomas, and in some cases it works. Eribulin, though it's another systemic chemo agent, not approved for leiomyosarcomas, but in the trial, I think it is an agent that works for some patients. So when I run out of options and we don't have trial options, we've tried Eribulin. It was compared to dacarbazine, which is also a reasonable choice for leiomyosarcomas, which is why we probably didn't see much of a difference between Eribulin and dacarbazine for leiomyosarcomas. And then beyond that, you know, it's looking at clinical trials like, you know, Breelyn mentioned enlotinib. It also seems to work for certain leiomyosarcomas, even those that have progressed on Votrient sometimes. So that is, you know, available as a trial option. I usually get most of my leiomyosarcomas, you know, genotyped. Again, immunotherapy is not something that comes up high, but we've enrolled patients for some reason if their tumor has markers that tell us a high PD-L1 that once we've exhausted other options, they would be eligible for a particular trial. We look into that. So I would recommend, you know, genotyping of your tumor and, you know, speaking to your oncologist available clinical trials that are out there. And I, you know, through the National Leiomyosarcoma Foundation, there are some interesting trials that might be upcoming shortly. And Breelyn, if you want to add anything in terms of trials.
Yeah, I think you hit the highlights. I mean, there's the one out of Memorial Sloan Kettering too. I think it's just the PARP inhibitor and immunotherapy, I think. but I don't know, that might be full. I mean, there's definitely leiomyosarcoma studies around, and I think just kind of digging through, you know, the patient advocacy foundations, whether it's National Leiomyosarcoma Foundation, or, you know, some of the other ones, there's really good links to various different clinical trials that are out there. So between, again, it takes a village to get a second opinion if you're not sure, and you know, really try to look and see what's out there.
And now I'm going to go with Dr. Rojas, give her a little, what are risks and benefits for middle-aged women on BHRT, bioidentical hormone therapy with the sarcoma diagnosis?
Yeah, I'm so glad somebody asked this, because I feel like bioidentical hormones, a lot of women are taking them and they may or may not even disclose that to their providers. So this is the deal with bioidentical hormones. First, let me say that I'm a huge proponent of hormone add back therapy, of giving patients back estrogen whose ovaries aren't working, as long as it's safe, with their oncologist. Now, an estrogen got a bad rap about 20 years ago. There was a trial that came out called the Women's Health Initiative, and basically doing a deep dive on that trial and other observational trials that were similar to that, you know, the media really picked up this thing that estrogen was bad for you and increased your risk of breast cancer. But when you look back at the data, that actually isn't true. And it can also be protective in some ways. And because that was blown up into such a huge, is picked up by the media and really changed a whole shift in culture, even among gynecologists, it's kind of bled into different aspects of not only healthcare, but cancer care, specifically with regards to prevention, but also in how we think about giving hormones back to women. But it's also led to these like side businesses of like non-FDA regulated products going out with the marketing that they're like safer. So this is the deal. Bioidentical hormones, like most of the products on the market today, are the exact same molecule that your body makes, and they are bioidentical. We just don't say bioidentical because bioidentical is a marketing term. When you get these bioidentical hormones from that are not FDA regulated, they're not tested for purity, they're not tested to make sure the dose you think you're getting is actually the dose you're getting, and the conditions where they're manufactured are not checked. And there's been problems with like purity, not just with it not being the right amount of the hormone you think you're taking, but also there being things like fungus or other things in these drugs or these products that just aren't regulated. The problem with the whole industry is that a lot of times certain providers are titrating these medications, meaning they're giving you this special like designer combination that's just for you. But they're using that by, they're just deciding what that is by these salivary tests. So they're testing your saliva and saying, okay, this hormone is low by this much and this hormone is low by this much. So I'm going to make you this combination. But the problem is those salivary tests are not validated. These hormones fluctuate throughout the day. Those tests are prone to being not only giving you completely wrong answers, but being completely misinterpreted. We should not be giving patients any hormones based on these saliva tests. So if you need hormones, there are doctors that are going to give you the right dose, the safe amount, the safe way, whether it's by your mouth, whether it's by, a sticker that you wear once a week, whether it's through the vagina. I would encourage everyone to stay away from bioidentical hormones. It's a marketing term. And I think this became a big deal because back when like the only estrogen available on the market was Premarin, which is not a good product. It's like a bunch of different estrogens mixed together, comes from horse urine, which is not very appealing to I'm personally from Texas and we love our horses. So like, I get it, but that's not how there's so many hormone products on the market now that are the exact same molecule that your body makes. And so we're just not calling them bioidentical. So talk to your doctor. Don't take mixtures of hormones of unknown purity and amounts. And that may make me really unpopular, but those are my thoughts on that. Because a lot of times there can be other things in there that can interact with the other medications that we're giving you. And sometimes, we can tailor a regimen for you that will treat you even better and give you a better, treat your side effects better than something else from an outside provider.
Here I have a couple of questions about like which chemo to give. And I think there was a patient from Finland, and she had multiple metastases, and she wanted to know about gemcitabine taxotere chemotherapy. And another patient with a leiomyosarcoma wanted to know about if it's non-uterine, is adriamycin or doxorubicin the best treatment. And so, you know, we talked about there's multiple different sarcomas, and you know, we use our standard therapies, but we individually use that, recommend them per the individual. And so for first line, typically we use doxorubicin based chemotherapy, but for some patients aren't always eligible for that chemotherapy, and we use gemcitabine taxotere chemotherapy. So it is a little bit dependent upon you know, all the situations. I think that's something that you need to be talking to your doctor about. And again, you know, we are a big proponent at the Sarcoma Alliance that you are treated with a sarcoma expert. So not everyone has the opportunity to be treated by a sarcoma expert, logistics, financial, but at least have a sarcoma expert in your wheelhouse, right? At least you've seen once, and that could work with your local doctor. And so that's where we recommend our second opinions, not necessarily getting a second opinion from different sarcoma doctors, because we do have different opinions, but more just that you have an expert on board. And so, you know, we do offer grants to get those opinions. So I have to give that little shameless plug. But I'm going to ask Dr. Somaiah, when's the best time to get genomic testing? Because that was a question from actually Michelle, from one of my patients in Georgia. She wanted to know when's the time to get the genomic testing. And we can talk
so again
too, and the difference.
Yeah. So in terms of when to get genomic testing, it's, you know, I usually consider it for all patients who have locally advanced or metastatic disease. Basically, you know, if you have your tumor completely resected in your surveillance, it might not be as critical at that time, because I feel that, you know, if you needed a therapy option later down the line, sometimes these panels do change and add newer things to the panel. So it would be useful to do it when it's most applicable. But when you have metastatic disease, it does take time to get the genomic testing results back. So it doesn't immediately inform your first line of therapy if that's when you're presenting. But if you are, we send it off. When you have metastatic disease, we start with our standard, you know, treatment options. And when those results are back, we find if there is anything that trumps, or there is something that is targeted, just like Breelyn mentioned, if there's an NTRK fusion for an undifferentiated uterine sarcoma, you know, we want to get that up front, because there's a likelihood you have that NTRK fusion, and, you know, we'll start therapy, but when the fusion results are back, we'll switch therapy if there is a identified druggable oncogenic target that we know, you know, it would work by using targeted therapy. With regards to, you know, also, it's also a little subtype specific in my practice. There are certain subtypes for which we know, we've been doing this genomic testing for a while, where we know there's a higher likelihood of finding an abnormality that is targetable versus not. So for like a D. diff liposarcoma, if we know they're MDM2 CDK4 amplified on the FISH based on the PATH report, it's not immediately urgent to get genotyping results, because that has rarely provided any additional, you know, information beyond that in terms of a target. So it's also a little bit subtype specific.
Very much. And people have been texting me and saying that I'm out of time, and I'm so sorry. And also want to give a shout out. We do have Dr. Sanfilippo actually on the call. I didn't even realize she's like the high grade endometrial sarcoma expert. So sorry, I didn't see that and ask you directly that question, but next seminar, we'll definitely have it. And just want to thank everyone. Really, you know, I'm sorry if I didn't get to all your questions, but hopefully, you know, we answered them in a different way. And I just want to thank all the panelists, Dr. Rojas, Dr. Venkat, Dr. Wilky, Dr. Somaiah, really outstanding women in this field. And thank you to Sarcoma Alliance for putting this on. Again, make sure that you get your fashionable masks. We have different kinds, and again, make sure that you are with a sarcoma expert somehow involved in your care.
Thank you so much, Dr. D'Amato. Thank you so much to all of the panelists. We really appreciate you taking some time today. This webinar will be available on our YouTube channel following this event. And as Dr. mentioned, grant cycle will end March 15th. So if you would like to follow up with any of the institutions that you see here today to secure a second opinion, you can apply to our grant program up to $500 to reimburse for transportation, as well as telemedicine even. So thank you so much. Really appreciate you all. And you can always visit our website at sarcomaalliance.org for more information as well. So thank you to everyone.